Hello, my name's Elizabeth Sapie. I'm a professor of acute and respiratory medicine, and I'm a clinical consultant working at University Hospitals Birmingham in the acute medicine department. I'm really sorry I'm not with you there today. I've enjoyed attending all of the webinars so far, but unfortunately, as Birmingham is right in the middle of the second wave of COVID, our clinical duties are moving around a little bit, which has made it difficult for me to join you today. However, I wanted to keep our appointment to talk about COVID, and in particular, what health data has done for COVID care and how it has better equipped us to face the pandemic. So I have a presentation for you, which we'll go through together. When we knew that COVID was coming over the landscape, we could see the devastating effect it had had first in China, and then in Italy, and then Spain. There was a high degree of anxiety and uncertainty in our clinical colleagues across the country. None of us had faced this particular infectious disease before, and the tools that we usually rely on to tell us how unwell someone is had not been tested in this new disease. Our clinical compass was off. We were unsure how patients would do. We had no prediction tools to tell us what was likely to happen to the patients that we saw. There were no treatments to offer our patients as well. And there was no time to conduct the serial clinical trials that you would usually conduct to gain knowledge about this illness. Fortunately, what we did have was high quality health data from China, and then Italy, and then Spain. And this provided our only means of understanding the illness to begin with. These data told us about the disease itself, its incubation period, as shown in this diagram, from the day of exposure to the illness, to when people might get symptoms at about day 5, to when they might be clear of the virus, and when to expect people to be hospitalized. Data also gave us information about who was most at risk from COVID. We knew from studies from China that the kind of people that did less well with COVID, the kind of people more likely to die, were those who were older and those who had specific long-term medical conditions, including cardiovascular disease, diabetes, and those that were overweight, in particular those with obesity. This was incredibly useful because it gave us a framework to understand who we needed to watch out for when they came into hospital and who was most likely to need to be reviewed for admission to critical care. We were able to apply these risk factors to our British population by studies that came flying in as COVID hit London. And from these studies, we could see that many of the risk factors were the same, even though our population didn't really match that of China. Age remained the greatest risk factor. We could also see that males tended to do less well than females. And there did appear to be an initial signal of perhaps those of Black or Asian minority ethnic groups doing worse. We were also able to understand in our own population that medical conditions such as obesity, diabetes, hypertension, and heart disease were predictors of people doing less well. It was good to be armed in this way, but the COVID pandemic, especially in the first wave, also caused a complete reconfiguration of hospital services. We needed to change the way we practiced medicine and change it quickly so that we could look after those with COVID whilst keeping our non-COVID patients safe. And again, this is where health records, digital health records, and health data came to our aid. At UHB hospitals, with the help of the Pioneer Hub, we were quickly able to make a COVID-specific admission document. This captured all of the information that you would need to make a clinical decision for that patient within the first 24 hours of them arriving at hospital. It also included prompts to tell you, the clinician looking after that patient, how unwell the person was now and what treatments they might benefit from. This was hugely important because we didn't have just the usual doctors working in the emergency department. We had a huge rush of doctors from other clinical specialties coming to join us. These doctors had sometimes not been working in the front line for years, so we needed to make data capture and caring for patients with COVID as easy as possible. We were also able to look at the evidence for those who tested negative for a first swab, then positive for another, to understand how accurate our swabs were. And this enabled us to make clinical pathways as to what to do if somebody had a positive swab, which was to continue using PPE, which is the personal protective equipment, and follow trust policies in terms of the patient pathway. But also if they were negative, we began to understand that the swabs were only 75% accurate in diagnosing COVID, meaning that 25% of positive cases could come as a negative on first swab. So using this information, we were able to make clinical pathways where if there was a high clinical suspicion of COVID, the medical team thought that COVID was highly likely, we knew when to re-swab and to confirm that negative result, or to make sure that those that were swab negative but actually had COVID were looked after in the appropriate place. It was really important for us to be able to map our COVID positive patients as they came through the hospital, so we could ensure that they were being cared for in the appropriate place, but also so we knew how many COVID positive patients were in the hospital at any one point, and vitally where they were as well. This allowed us to make sure that ward staff were adequately placed where there were the highest level of care needs, and there was adequate personal protective equipment, PPE, for all staff on that ward. The way that we did it is that we rapidly initiated a B system, which you can see with this little B symbol here. All patients who were COVID positive had a B symbol by their names, meaning you could select from a whole 1,000 bedded hospital to understand where the COVID positive patients were, but also where the suspected patients were. I would just like to reassure you as you're looking at this slide that all of the names for all of the care records presented are made up. So you won't see any names you recognize, or if you do, they don't pertain to anybody in particular. These are made up health records throughout this presentation. When people came into hospital with COVID, we needed a means to understand how sick they were. And there were already studies coming from China, Italy, and Spain, which suggested that certain blood markers were highly indicative of a poor outcome. A number of them really stood out. There was the D-dimer blood test, which goes up a little bit during infection, can go up higher in a blood clot, that could be incredibly high in COVID patients, particularly those that did less well. But there were other markers on bloods as well that we could use, and when you put them together, you could have a very clear and strong indication of who was the most sick. We were able to incorporate that into our electronic health system, so that if a patient was suspected of having COVID-19, an automatic blood bundle was ordered, all of the tests we needed to understand how well or unwell that person was likely to become in one place without relying on a busy junior doctor or nurse to tick the right boxes on a blood form. We also knew that COVID would cause an incredible amount of change in our working patterns. There were new rotas delivered. Some medical and nursing staff had to shield because of their health status. And all non-shielding medical staff, including myself, moved to 13-hour rolling shifts, covering the hospital day and night to make sure that there was appropriate staff there to look after the waves of patients that were being admitted. Looking after the front door, that's the emergency department and the acute medical unit, the respiratory wards, and our high density and intensive care units was the priority, because this is the kind of care that most patients with COVID needed. We were able to expand our ITU capacity. from 100 beds to 250. We knew that some vulnerable people were being admitted from care homes. So UHB Hospital took the unusual, and I think pretty fantastic, idea to send patients home not only with a packet of drugs that they might need, but also packets of PPE, personal protective equipment, so that they could be cared for safely in their nursing homes. Our shielded staff moved to a completely different way of offering outpatient care to patients by doing virtual clinics, first by telephone and later by video conferencing. And they could do this from the safety of cold sites where no COVID patients were, to protect these shielded staff. We have a busy research unit at UHB Hospital with 80 whole-time equivalent nursing staff, but these were redeployed. Over 900 of our studies were paused. We managed to keep 75 open. Those 75 we kept open were those relating to cancer care and where the study was really the last opportunity for care or for treatment for patient groups. All elective treatment was cancelled in hot sites in places where we were admitting high numbers of COVID patients. We did this hugely reluctantly because we knew that the impact it would have on people waiting for vital investigations, operations, or treatments. But we did keep one cold site open in one of the 4 hospital units which makes up UHB. This new way of working meant that many doctors that hadn't worked in acute services before were redeployed to the front line, and they needed support to help them act with confidence and to help avoid any errors that might occur purely because they hadn't worked at the front door of the hospital for such a long time. And we did it all wearing PPE, and this is a picture of me looking particularly delightful and rather hot in this equipment. In order to understand where our patients were and where our staff needed to go, Pioneer quickly used health data to produce clinical dashboards. We started on the 5th of March. This is one from the 15th of April, when the first wave was in full swing. And for each of the 4 hospitals, we were able to look across and say, this is how many positive patients you've got in your hospital at the time, how many were new, tested positive that day, how many had results pending. We could break up what these patients looked like by their age group and gender and ethnicity, and we could also look into the severity of their symptoms. You can see in the bottom panel that we also were able to use this information to map intensive care beds. There was huge anxiety and uncertainty that we might run out of ITU beds or ventilators over the course of the first wave. That's why the Nightingale hospitals came into existence. And although the Birmingham Nightingale was ready, I'm pleased to say we never had to send intensive care patients there because we were able to carefully manage our beds across our hospital sites in Birmingham to make sure that if a bed was needed, one was available. It did get awfully tight. So at one stage we were down to our last 4 ventilators, but I'm pleased to say we were always able to deliver the care that was needed when it was needed. We also were able to look to see what was happening to non-COVID patients that were admitted to hospital. And using this health data, we could see that there was a reduction in young adults presenting to our hospital. There was a reduction in non-specific chest pain, a reduction in non-specific abdominal pain. But there were increases in some problems. Over lockdown, there was an increase in alcohol and drug misuse, and an increase in psychiatric ill health that required admission to hospital. There was also an increase in falls, particularly in the socially isolated, and these might give you an indication of the unintended impact of the lockdown. We very quickly had to adopt to new treatments and new ways of working, and this is again how our electronic health system came to the fore. There were many treatments that we hadn't used before, such as high-flow nasal oxygen. High-flow nasal oxygen can give oxygen at a flow rate of sometimes up to 50 litres a minute. It's part of the reason why some hospitals around the country run into concerns about running out of oxygen, something that we'd never been faced with before. But through structured prescribing and careful management, UHB didn't get close to that because we knew at every point in time how many of our patients were on high-flow nasal oxygen, what the flow rate was, because we had a structured prescribing system, as you can see here. We also knew that sadly many patients would die, and we had to make sure that they died with comfort and dignity, so that the end of life did not mean the end of the care that we received, that we gave to them. Usually we would give medications at the end of someone's life via syringe driver, a little syringe attached to a pump, which gives people medicines that they need on a steady basis throughout every 24-hour period. But we also use syringe drivers on intensive care, and there was concern that we might run out of them, and that doctors that weren't used to prescribing end-of-life medicines might suddenly be faced with uncertainty about how to prescribe them in a different format. So we formed some clinical prescribing prompts to make sure that all you had to put in was end of life to the computer system, the electronic prescribing system, and it would suggest safe ways of delivering end of life care to prevent people from suffering, to reduce their symptoms, but also in a way that provided confidence to prescribing staff. During the pandemic, and still now, it's very difficult for us to have family members in the hospital with patients because of the potential risk it places on that family member coming in, but also the risk that family member places on the staff and other patients because of the potential of COVID spread. But we also recognised it would be incredibly frustrating for family members and loved ones not to have regular updates about how their family members were doing whilst they're admitted. So this is where we utilised our shielded staff again, who couldn't be on the front line. Using our family liaison service, we were able to set up a system where the clinical team looking after the patient wrote copious notes about what information needed to be passed to the family members. And then the family liaison service were able to pass this on to worried family members at home to give them regular and frequent updates, as well as providing contact for people through tablets and FaceTime and other such platforms. And the use of these tools rocketed. So this is a graph where you can see time at the bottom and the number of notings at the top. And you can see usually on an average time at the hospital, there'd be between 100 and 150 communication with relative inpatient notings completed. During the pandemic, this rocketed to up to 400 communications with family members. And every time there was a communication, even if one of our family liaison service called a family member on multiple occasions during the day, it would only count for one contact. So there was a huge amount of communication to make sure that our patients didn't feel isolated and our family members at home had a clear picture of what was happening. So what did we learn from the Birmingham experience? Well, this is a slide which tells you about our cumulative experience of COVID up until the 3rd of November. So a little bit out of date now. And I know Susie will be listening to this webinar, and I know she'll be raising her eyebrows now, cross that I haven't put in a more up-to-date slide. I'm sorry, Susie. We were able to pull together through Pioneer the total number of tests that were done across our 4 sites, which on the 3rd of December stood at 62,000, the number of positive cases we'd had in our hospital, and the current number of positive inpatients, which in the 3rd of November stood at 363. Unfortunately, that's much higher now. Again, we were able to break down the tests by age and gender, the deaths as well by age and gender, how severe people were when they came into hospital, and what COVID looked like for us as a hospital from the terrifying peak of the first wave to this more sustained and slow peak in the second. In the bottom corner, you can see that there's a map of Birmingham. At the beginning of the first wave, there was no community testing for COVID. So we knew who was positive who came into hospital, but we knew nothing about the positivity or the amount of COVID that was around them at home. However, we did know people's postcodes. So we were able to use this to reflect where there were high positive caseloads in the community, because that's where we were seeing patients coming from to hospital. Now, of course, hospitalized COVID is only the tip of the iceberg. It's only that little bit of the most severe cases. But through sharing this information with Public Health England, we were able to look for care homes, for example, with high levels of COVID, or pockets of our communities which were experiencing a particularly high burden, to try and investigate why that might be and what we could do to prevent it. Putting all of this data together allowed us to do some analyses of what our experience of COVID was like. And this is a survival graph looking at the percentage of people that have survived to the days from swab. You want to be 100%, you want everyone to survive. But what you can see is there was a step down increase in the number of people that died based on age. So our experience reflected that of other countries. The older you were, the less likely you were to do well with COVID. We were also able to look at the burden of comorbidities. Comorbidities are when people have multiple long-term health conditions. And we could see, again, looking at survival, that those with no comorbidities did better, and those with 3 or more did worse. But we were also able to look to our own population to understand the burden of COVID more. Birmingham has a high number of people who are South Asian in ethnicity. And we were able to look to see what the impact of COVID was on this very important part of our community. And we could see that those who came from a South Asian heritage had worse outcomes than those from other ethnic groups. And we were one of the first publications and the first data to provide to SAGE, the Government Advisory Committee, to warn them that some patients from Black or Asian minority ethnic groups had worse outcomes for COVID, which we were not able to explain by some people being poorer or some people having more health conditions. And this has started a huge amount of research to try and understand the reasons for that. We were also able to look at our staff members to see which of those had seroconverted, that means had developed antibodies to COVID. And we could see in the places where we assumed there'd be the greatest risk, intensive care, the emergency department, actually the rates were lower than the average in the hospital. And some of the highest levels we saw were acute medicine, where I work, but also in people that keep the hospital running for us, our support services, our housekeeping services. And this led us to be concerned that we needed to do more to protect this group of patients. But when we looked at the spread of COVID and when these people developed antibodies, we could see that the majority of seroconversion, the majority of people who were testing positive for antibodies, actually had symptoms of COVID before the lockdown and also before we started to see the rise in admissions at the hospital, suggesting that many of our staff members were affected because they caught COVID in the community. This obviously still made us want to look after our staff, our patients, and the people that come into contact with us. But it helped reassure us that the steps that were taken at the beginning of the pandemic to care for patients and staff members had been effective. Putting this all together, we developed this COVID roadmap of understanding where our COVID patients were coming from, what they looked like in terms of their demographics, their age, their ethnicity, their gender, what biomarkers and blood tests we needed to use, how we could give people effective treatments to make them feel better, how we could look after our staff to keep them healthy so that they could look after our patients. And then as we came out of the first wave, how we could reopen services as safely as possible and then plan for a second, knowing we would never want to close our services down in the way that we did before. And I would just like to thank Michael Hughes, Kylie Bell-Chamber and Ellie Walker, who did the amazing infographics you've seen. And of course, all of the staff and patients at UHB. I hope that's given you a brief taster of what it was like on the front line and how we were able to use health data rapidly to look after our patients, our staff, and provide the very best care we could. And I know that Susie will be taking questions about the technical side of it, but we'll also be joined by Kat Atkins, who's one of my registrars, who I'm sure would be happy to answer questions that you may have about the clinical questions or the clinical care that we provided. Thank you very much for your time.